back again. Thank you, Chip. No words. Chip is in the back checking to the question. Is incredible. I will tell you about our Italian experience. The B cell phenotype is not a clinical phenotype, of course. I will tell you about some unpublished data on the work of Francesca Aschena on the B cells and T cells in this patient. But the general, and all these data are unpublished. Our aim was to study and analyze the prevalence of CHEK1 mutation in the Italian patient for follow-up for early onset pan-like disease or neurological manifestation in the context of systemic inflammation. So these were the inclusion criteria: histology confirmed polyarteritis nodosa or cutaneous polyarteritis nodosa, persistent livedo reticularis with elevation acute phase reactant, or ischemic or hemorrhagic stroke with systemic inflammation. We also had an enzymatic activity on monocytes. We isolate the monocytes with adherence in peripheral blood. So we had adenosine together with an ADA1 inhibitor, and we collect the supernatant after 4 hours, and then we test for inosine and epoxanthine with HAPLC. Results. From April 2014 and to June 2016, we were able to collect 48 patients from 43 families from 11 pediatric rheumatology centers, because the environment was mainly the pediatric rheumatology centers among the Italian centers. 15 patients came out to be homozygous and compound heterozygous for CHEK1 mutation, and 2 were heterozygous, just heterozygous for this mutation. 31 came out to be negative or carrying common polymorphism. These were the families that we were able to study. I will come back on that later on. We were able to identify novel mutation that seems to be rather typical, especially this mutation that account for almost 50% of allele affected. That is, seems to be a sort of an Italian mutation. The mean age at onset was 2.9, so very early with different possible presentation. I don't go into detail because you already heard about the clinical presentation that were pretty much the same of the other cohort: livedo reticularis, nodules, ulcers, and hemorrhagic and ischemic stroke that you can see can be, of course, together. One important thing in our cohort was the acute hearing loss. That is very dramatic because it's a complete and acute hearing loss in 3 out of our patients. Hypogammaglobulinemia was seen just in 6 patients, and just few of them receive IGV. I would like to point out the problem of the patient that with a typical phenotype with an incomplete genetic test. I think it's a relevant question. In this family, for example, we have these 2 brother and sister that have the classical phenotype. They are just heterozygous, like the father and the healthy brother, and the healthy brother. They have the typical presentation with livedo reticularis, subcutaneous nodules, necrotic ulcers, hypogammaglobulinemia, and so on. As I told you, with the test, we were able, in the severe patient, to have a completely block of the production of inosine. In patient 4, that is quite rather interesting, there is a sort of residual enzymatic activity. Patient 4 was the mildest patient that we have. He has just a sort of cutaneous pan. And you can see how different is the situation for the secretion of inosine in a control patient that turned out to be negative for CHEK1 mutation. And you see what happened in the family. The 2 patients with the clear phenotype have the same also functional phenotype of the patient. For sure, there is a second mutation maybe in the mother that we are not able to find out. I think this is a relevant question, and I think Ivona will address this in his next future. There are plenty of very interesting information coming from this family for this heterozygous patient. For example, this here there is a father that have a ischemic attack, cardiac attack at the age of 40. There is this very interesting family in which there are two homozygous with the Italian mutation, let's say, and there are, for example, the mother had the vasculitis and ischemic stroke. The father died at the age of 38 for a ischemic attack, a cardiac attack, and these two little guys had both, very young in age, a Kawasaki disease that respond normally to immunoglobulin. So this is how the being an heterozygous patient affect the phenotype, in my opinion, could be an interesting aspect in the next future. What about the genetically negative patient? Because we have the genetically positive and genetically negative, 31. We have the chance, it's a very busy slide, to study 20 in detail 21 of the Czech negative patient. And you can see that the positive patient have a much earlier disease onset, 2 years versus 7 years, much more livedo reticularis, much less subcutaneous nodules, and much more CNS involvement and peripheral nerve involvement. Among these genetically negative patients, we have one Sardinian patient that very early start with fever and livedo reticularis with myocarditis. That is also the clinical presentation of another patient with 2 mutations, and hypogammaglobulinemia. She did not respond to anakinra, she responded to steroid, and she stayed on low dose of steroid for several years. And when she withdrew the steroid, she had several strokes. She is, again, negative for wild type for, and we are looking for different possible mutation. And she, again, this is the patient, behave like a healthy patient in the enzymatic activity. So there are some genetically negative, let's say, patients that behave really clinically, enzymatically, and so there are plenty of things to do from the genetic point of view. What about the B cells phenotype? This is the work of Francesca Schena. So I mean, she studied B cells and T cells function in this patient. First of all, she want to find out how CHEK1 is expressed in B cells and is expressed. The B cells are able to secrete ADA2, and this was clear in naive B cells stimulated and also in ABV cell lines. And what is quite interesting, and these are very preliminary data in ABV line coming from the patient and some health individual, that together with our biochemistry, she was able to find a true deficiency of the ADA2 activity in the B cells, the ABV line in the patient. That is not present in the BV line of a control patient. This seems to be something that tells us that B cells have an important function also in ADA2 activity. As we already know, there is a reduction of total memory and switch B cells. Francesca was also interested in to see the T cell compartment, and there is a decrease of all the subpopulation of T cell department. What was quite interesting to study was the co-stimulation of T cell and B cells, and it was clear that there is a clear defect in the proliferation when the B cell, the T and B cells are activated by GPG and CD40 ligand. There is a clear defect you can see here of proliferation and also of secretion of immunoglobulin. And what's quite interesting that this defect is also present when B cells of ADA2 patient are co-stimulated with T cells of healthy individual. But this came in the same way when B cells from healthy individual are co-stimulated and co-cultured with T cells from ADA2 patient. That means that could be also a T cells defect in the HELP. for B cells activation and proliferation. You know that the follicular helper cells are quite relevant for this differentiation of B cells, especially with IL-21. When we study the follicular helper cells in the circulation in ADA2 patients, we saw that there is an overactivation of an overexpression of these follicular helper T cells. And what quite interesting, there is a down modulation of the secretion of IL-21 in the supernatants when of the co-stimulatory experiment, when the T cells of the DADA2 patient were included in the experiment. So it seems that T cells of DADA2 patient secrete less IL-21 that is so important for the differentiation and activation of B cells. So the conclusion of this B cells part is that B cell express CHEK1 and actively secrete ADA2. There is a data that ADA2 is able to bind to the B cell surface. There is so the possibility of an autocrine loop, and our data seems to say that there is a possible intrinsic defect of B cells in DADA2. For sure, monocytes are really important for we will see the oral presentation later on, but maybe there is also the room of an intrinsic defect of B cells and also a possible role of the intrinsic defect of T cells. What about response to treatment? We are already known anti-TNF treatment was very effective in all patients that were treated. Now the follow-up is, for some patients, very, very long, or more than 13 years. We have the chance to analyze the monocyte, the secretion of TNF in monocytes isolated from ADA2 patient. What was quite interesting, because it's not that easy to study a patient in active phase of the disease without treatment and so on. There is an increase also in patients in remission and in treatment, especially with LPS. But you can see here what happened in these patients that were in active disease before anti-TNF treatment. You can see huge amount of TNF secreted after LPS and zymosan stimulation. And you can see, again, in the same patient, what happened when we, after treatment. After 3 months of treatment in complete well-being, we redo the experiment, and the secretion of TNF was really incredibly reduced. What about another aspect of response to treatment that was rather unexpected, because they came from different centers? Most of these patients also receive thalidomide, because you know that was a drug that has a relevant anti-TNF effect. And I have to say that 6 out of 7 of these patients had a complete response. That means no thalidomide as a single treatment without any relapse and without any use of steroids. And that is quite interesting, in my opinion. In one patient, the treatment was done for 10 years, and he has a stroke when the thalidomide was withdrawn, and he was again put on thalidomide with good control. One patient is now in treatment with thalidomide after 20 years, but on the other hand, I have to say that 3 patients have to withdraw this drug because of neurologic toxicity. But I think this could be a good option, especially in those patients in those countries in which the biologic are not available, and it's difficult to find that. Alexander will talk about the possible role of interferon alpha and beta in DADA2. I don't want to bore you. Just a provocation to Alexander, so I'm very curious to say what you say. We are doing, of course, the same score in collaboration with Yannick. And I want to show what happens when we make the interferon signature in 2 brothers that have the same mutation, the same treatment, the same complete remission, the same day. And you can see one brother have one of the most higher interferon signature we have ever seen, and the other was completely normal. So now it's to Alexander to explain me with this kind of variability. So in conclusion, CHEK1 mutation are present in the Italian population and associated to a severe DADA2 phenotype. There are new mutations, and I think some typical Italian mutation, I think. A typical phenotype can be associated to an incomplete and negative genotype. I think this is really important and something that we have to address in the future. Thalidomide as a possible alternative treatment. There are still, of course, as Jacob pointed out, a lot of open questions: genotype-phenotype correlation, long-term follow-up, safety and efficacy in the long run of different treatment. I think that we really need for a common registry, and this is just to, of course, to remember to everybody that we have a sort of experience in Europe, thanks to the Printo network, for the possibility to make a registration of different autoinflammatory diseases, including DADA2. And there is a tool that I think is rather relevant for that give the possibility to follow the patient longitudinally, especially for the treatment, and to have a clear idea on also the side effect and the efficacy of the treatment in a prospective way, in a more precise way. So just to thank all the people, only to say that Francesca Schena is here, and so if you have questions of B cells and not the B cell, then go to Francesca, and no, but however, I'm more than happy to answer. And just as an Italian, I cannot refrain to say that sometimes they come back. We are in a same family, and I argue. Thank you very much.